Yes, sir. Good evening, sir. Hello.
Good evening, friends. Warmly welcome to you, all of you, for this today's edition of the Postgraduate Clinic. We have two important presentations. One on carcinoma breast, uh, kindly contributed, Abhi Vignesh, kindly contributed by Dr. Pabita ma'am from Valley Medical College. The other boy is Dr. Shakil, case of peripheral artery disease, kindly contributed by Professor Heman Nadia, Himalayan Institute of Medical Sciences. Today we have very eminent faculty, Professor Seema Khanna ma'am, Professor and HOD, Institute of Medical Sciences, Banaras Hindu University. And we have Professor Shilpa Rao, Professor of Breast Surgery Unit and General Surgery Key. She is from KEM Hospital and St. GS Medical College. We have Professor Kalivani ma'am joining from Bangalore, Vaidehi. And we have somebody very important, very eminent teacher, and she represents to the Association of Breast Surgeons of India. She is Dr. Anjali Davle. She is a private practitioner, but very good teacher, so we have requested to join. So she is from Nanded, Davle Hospital, Nanded. Welcome, Davle ma'am. And we have our own faculty, Professor Sahai sir, and other senior faculty who are joining us shortly. So we will have two cases now today. So we'll have the CA breast case first. Dr. Abhi, can you introduce yourself, your unit chief, and start your presentation? Madam, good evening, Madam Shilpa ma'am, welcome. I was trying to reach you. Thank
Yeah,
you for
good
joining.
evening. Sorry. I kind
No
of.
worries, ma'am. No worries. We just don't want you to miss the initial part.
Sure.
Thank you for joining, ma'am. We'll start the discussion. Yeah.
Good evening.
Abhi?
Please, can I share my PPT, sir?
Yeah, please, Abhi.
Yes.
Nishi sir, good evening, sir.
Good evening, faculties. I'm Dr. Abhi Vignesh.
Sir, good evening.
Please start. Please start. Good evening, sir. Please start. Abhi, please start. Good luck.
College General Surgery Department. My HOD and chief is Dr. Babita Devi ma'am, and my other chief is Kamalin Vijay ma'am.
Abhi, we are unable to see you. Can you please check that? Yeah, now it's good. Please go ahead. Yeah.
Sorry. Yes, sir.
Best wishes.
Okay.
Faculty, please take over.
A 48 years old female coming from Rajapalayam, belonging to upper lower socioeconomic status, presented to the hospital with complaints of lump over the right breast for 25 days. And history of breast illness, the patient was apparently normal 25 days back. Then she noticed a lump in the right breast while bathing, which was insidious at onset and with no noticeable change in size. There was history of pain over the lump for the past 5 days, and following biopsy from the lump, which was sharp pricking type and delayed by medications. And history of bluish discoloration of skin over the lump for 5 days following biopsy. And there is no history of nipple discharge, no history of nipple retraction, no history of fever, no history of trauma, no history of swelling in the axilla, and no history of chest pain, no history of breathlessness, no history of cough with hemoptysis, and no history of abdominal pain, no history of headache, no history of backache, no history of loss of weight and appetite, and no history of lump in opposite breast. Past history, she had no known comorbidities and history of sterilization done 21 years ago. She had no previous history of surgery in breast or axilla. And personality, she had no history of smoking or alcohol intake. The patient consumes mixed diet. She had normal sleep pattern and normal bowel and bladder habits, and there was no history of drug intake, especially ossifants. Family history, there was no history of similar illness in the family members, or there was no history of ovarian malignancy in the family members. Menstrual history, he attained menarche at the age of 14. She had regular cycles of 5 per 28, and the last menstrual cycle was 10th of this month. And obstetric history, the age of the first childbirth is 22 years. obstetric score is P2, A2, and L2. She had 2 abortions in between the 2 child. The age of first child is 25 years. He was normal vaginal delivery and was breastfed for 1.5 years. And the age of second child is 21 years. He was also normal vaginal delivery and breastfed him for 6 months. And summary: a 48 years old perimenopausal woman with no known comorbidities presented with a lump over right breast for 25 days and pain over the lump for 5 days with no nipple discharge or nipple retraction, probably a case of carcinoma.
Okay, Abhi, can you hear me?
Yes, ma'am. Yes,
Okay.
ma'am. But
First
I'm
of
not
all,
able to see you.
sorry, you're not able to see me.
Yes, ma'am.
Okay, that's okay. You can hear me, right?
Yes, ma'am. Yes, ma'am. Sure.
Yeah. Okay. A, you went like one of those Toronto expresses. You need to give us some time to digest what you're saying. I mean, it was a good compilation. It was a comprehensive compilation, but take a breath and talk. Okay. I mean, I had to
Yes,
really
ma'am.
concentrate on what you were saying. Okay.
Sorry, ma'am.
Having said that, can we go to your diagnosis? Your some whatever is your clinical diagnosis.
Yes, ma'am.
Yeah. Okay. So the first thing that hit me, we're not having a pathology exam, right? So carcinoma of the breast is a very wrong term to use.
Okay.
Yeah, you say malignant neoplasm, you say malignant lump of the breast, you do not say carcinoma.
Yes, ma'am.
Yeah, that's point one. Now, in Indian women, we have a lot of different factors which cause malignancy in our setup. So, what in your history do you think are the positive factors?
The first thing, the age being considered, ma'am, she's a 48 years old woman, ma'am, and she's in the perimenopausal age group, ma'am, around 50, and she had initially had a painless lump, ma'am. These are my
Okay,
only positive findings I could say. She had pain because a core needle biopsy was done
that's
5
it.
days
Okay,
ago, ma'am.
I understand. So, how about the two abortions that you talked about?
Yes, ma'am. She between the two childs, she wanted spacing, so she aborted, ma'am.
Yeah, yeah. For whatever reasons, any kind of abortions or miscarriages become a high risk factor, right?
Yes,
And
yes,
why
ma'am.
is that?
Mm, sorry, ma'am. I don't know.
What happens in the first trimester of pregnancy?
class நடக்குதுமா பேசுறீங்க.
Okay, you've gone off somewhere, and there's somebody else.
No, no,
I'm
no,
not
no.
able to see you. Yeah,
I'm sorry, I don't know. I couldn't
huh?
explain further.
I can't hear you.
I didn't understand the first question. What
Abhi,
happens in the
are you
first
with us?
trimester?
Avi, can you go to your first slide?
I think he's disappeared.
I'm here, ma'am.
Okay.
Yeah.
Probably he has some connectivity issues.
So,
Yeah. So, can you answer that question before you go on further?
That first trimester.
Yeah.
Maybe.
What happens in the first trimester? So there is an increased estrogen, unparalleled estrogen stimulation in the first place. It's not protected by progesterone. So any number of miscarriages or abortions become automatically a risk factor, right?
Yes, ma'am. Yes,
And you
ma'am.
also mentioned about family, only ovarian and breast. Is that all that matters?
Any abdominal malignancies also we can include.
No. Any abdominal means what?
Colonic malignancies we can include.
So only in the women counterparts or anywhere? Like maternal,
In male
paternal,
also we can ask for prostate,
yeah, prostate and
pancreatic malignancy.
thyroid, certain gastric malignancies. So you have to ask for a very comprehensive history of malignancy in on both sides. And there's a very lovely chart which is given, which talks about the risk factors, depending on the number of family members who have malignancy. You have a chart. You can go back and look. And it tells you
Yes,
about
ma'am.
the absolute risk factors that are involved with one member, two members, three members, and things like that. Yeah?
Yes.
Okay.
Yeah.
Somebody else was asking you questions.
Yes, yeah. Avi, I have a question. This is your first slide. So when you
Yes.
introduce the case, you have to give your complaints of the patient in the chronological order. Here you have written in a story form, so that's not the correct way to put it, right? So put the
Okay.
presenting complaints in the chronological order. What are the presenting complaints? This is not the right way to put it, right? So how should you put it?
Um,
So it should be like lump over the right, 48-year-old female presents with a lump over the right breast for 25
okay.
days. Then I think there was history of, in your next slide, history of pain
Pain. But I
for
was able to
5
elicit
days.
only after in asking about the pain specifically, ma'am.
Yes, so
Initially, when she
this is
complained
the
about the lump,
only,
she didn't
that
mention
is
any
okay. You can
pain.
have just one complaint. You can have just one complaint. So presenting complaint, it should be presenting complaint. So lump in the right breast, 25 days. That may be the only complaint. That's just perfectly okay. But the
Okay.
first slide, the presenting complaint has to be enumerated in the chronological order 1, 2, 3. Okay,
Yes,
right?
ma'am.
Go to the next
Yes.
slide. So this is the mistake in your first slide. Go to the next slide.
Yes. Ma'am.
Yes. Then it is okay. Now you are coming to the history of presenting complaint, right? So here it is okay that or asking a lead question about pain, she did not furnish the information about pain.
No, ma'am.
Huh?
Here in relation with the pain, whether the biopsy was taken at your center or somewhere else.
Yes, ma'am. It was taken under the ultrasound guidance.
So that also you can
At
put in
your center.
history that yes, the patient
Yeah.
underwent biopsy, core biopsy, or 5 days back, after which she had pain. That way
Yeah.
you can put it, right?
That also you should mention.
Yes,
Because whatever madam is saying that when she noticed the lump, that is one size approximate size, so you can compare with the lemon or something like that. Okay, then how gradual is the increase in the size of the lump, then whether the lump since beginning was mobile or fixed. So you have to rule out whether benign is turning into malignant or the lump since beginning was malignant, so that you can get a rough idea. Here in your history, looking at it, we have an idea that patient has an pain only after the biopsy. Till that time it was a painless onset of the lump, isn't it?
Yes, ma'am.
How
Uh,
it is?
The history of biopsy, what are the points which suggest that it is a malignant lump?
It's a painless lump to begin with, ma'am.
Okay.
She had a painless lump. Most of the malignant lump will be painless. Ma'am.
Okay. Anything else in your total history which suggests that
Age.
it,
Another
huh?
thing I can substantiate is her age, ma'am.
Age is, I mean, she's perimenopausal, so definitively you can, it's not all in favor of a malignant lump, right?
Yes.
Mm.
may I interrupt for a second here?
Yes, ma'am.
Okay, again, one of the things about the Indian subpopulation is, Abhi, do you know what is the average age of incidence
It
of
is
breast
48,
cancer?
ma'am.
No, average, and please listen to my question before you start answering. What is the average age at which breast cancer is supposed to be present the world over?
I mean, in worldwide it is 60, ma'am.
It's 54. Okay, that's the
Sorry.
peak age. And in the Indian subset, what is the age?
I mean, in Bailey, I saw it as 48.
So it's not Bailey. I mean, it is a decade younger. So yes, so between 44 and 48 in the Indian subpopulation, you would still consider malignancy on top of the list. And my contention about the pain was you should not mention it as part of your history. It has happened following a procedure. right?
Yes, ma'am.
So it confuses everybody. So you, with this history of pain, you could have put right at the end somewhere saying that she had a biopsy and she had pain associated with the biopsy, which was done 5 days back. Okay.
Yes, ma'am.
And the
Yes,
other
ma'am.
thing Anjali also mentioned about mentioning the size. So Anjali, there have been a lot of examiners who make a lot of fun when you talk about fruits because, if there's somebody from Kolkata, the size of a lemon is different as compared to Kerala. So what we
Yes, ma'am.
suggest to our students is that you say approximately how much, like in terms of, she'll point out a couple of fingers, right? So approximately 2 centimeters, 3 centimeters. Okay. So we've had a lot of examiners, which generally want to create chaos. So play safe and, say it like that, right?
Yes, ma'am.
Okay.
Yeah. Can we go on to the exam now? Or is somebody else,
Yes,
Anjali?
ma'am.
Avigesh.
It's okay.
Dr. Hayo.
Yeah,
Hello,
yeah.
Avigesh.
Yes,
Sorry.
yes, sir.
Why you ask history of trauma? Is any
Sir,
significance?
yes, sir. Any traumatic fat necrosis or patient may develop a hematoma which can further change into abscess.
Change
So
into
patient
abscess
had
or something else? What is more significant?
What
fat
will
necrosis, we
happen to
can say.
the yes? What will happen to the
Sorry,
present lump if it has got a trauma? If
it has
malignant lump is
it
there since beginning?
can bleed within the lump that it can bleed within the tumor. It can bleed within
What is traumatic fat necrosis?
the following trauma. Um, there will be necrosis of the fat cells in the breast tissues, which can
Is there
present
any significance
painful
of this?
lumps. Pain,
Is there
since the
is
patient,
any significance?
sorry, sir, I don't see.
What are types of nipple retraction?
Circumferential nipple retraction, slit-like nipple retraction.
Anything
The
else which is
following,
clinically significant in
uh,
your patient?
no, sir, I couldn't see any nipple retraction in my patients.
No. I am just asking. You have mentioned that there is no history of nipple retraction. So which nipple retraction is clinically significant? History wise.
Circumferential
Is there
nipple
any
retraction is
classification? Huh? Hello?
circumferential slit-like nipple retraction may follow after mastitis or a sublingual abscesses. So they are not significant. Sir. Circumferential nipple retraction may suggest malignancies.
No, history wise.
It is whether it is of recent onset or remote. So the significance is of nipple retraction, which is of recent onset, right? That is what sir is asking. I think, ma'am, we can move to the next slide.
Ma'am,
Yes.
I'm Dr. Sahai. I just need to ask him.
Sir, you want to give the information before we move on? You were talking about the classification, so maybe if we can have that mentioned, then he can move on to the clinical exam.
Dr. Nishikant Kuja?
Yes, sir. Okay.
Yeah, I think.
Continue.
No, you have to tell the student about the retraction of nipple and about traumatic fat necrosis.
Traumatic part necrosis, it mimics like malignancy because its consistency is hard inconsistency. That's why it is one of the differential diagnosis. You have to keep it in mind. And regarding
Yeah, it's a
onset,
rare condition. It's a rare condition generally seen in elderly women with floppy breasts, where the breast gets struck by the elbow while sleeping and generally causes that. Doctor, I just want to tell you about your history. This is a medical MS exam, right? It's a post-grad exam. Don't give us the whole list of no history of headache, no history of all that. Just say no history suggestive of secondaries,
Yes.
right? We go
Yes,
to the
sir.
next slide, please.
Yes, sir. Adding this.
Right, all this, you might be missing something. No history of jaundice. Where is no history of jaundice? It could be your no, right? So you don't have to enumerate all of them because you could miss one of them, and then examiner pounds on you saying you missed this. So just give a broad picture that no history of secondaries,
Yes, sir.
right? Yeah. Let's go to your next slide.
If at all you mention, then you have to know the causes, that why you are mentioning and what are the possibilities in which this is positive.
Okay. No known comorbidities should not be in past history, should be in medical history. Next slide, please. Previous surgery in breast or axilla, right? Okay.
Yes.
Right. Next slide, please. Drug history. Okay. Next slide. Okay. Ovarian it could be the father suffering from CA breast, right?
Yes, sir.
Or the brother. So you have to take both the history of BRCA1 and 2 in both males and female relatives, right?
Yes. Yes.
Next slide. Now, next slide, please. If you suspect malignancy, you must take the social history because we want to know whether the woman can understand her condition and whether she'll be supported in her treatment or not by her family members, whether she can afford it or not, right? So social history is important, especially in malignancy. Right. Next slide, please. Okay. No known comment with lump right breast 25. Just for 25 days. I mean, it's a bit difficult. What was the size of the lump when she first noticed it?
3 centimeters, 3 cross 3.
3 centimeters. So you think, okay, maybe she noticed. You just say that she noticed it for 5 days. You can't say that lump has been there for 25 days only.
Okay.
That the patient noticed her lump for
Yes,
last
in
3 weeks.
history, I mentioned it as a
Yeah.
notice.
But in your summary, okay.
Yeah.
And probably a case of carcinoma. How can you say carcinoma just
Yes,
because
yes, sir.
you put a lump in the breast?
We discussed all
I know.
this already.
I said that. I just want to reiterate this point that you just can't
Yes,
jump into carcinoma just because she's 48 years old with a lump. Of course, that you have to rule out that, but you can't come to a conclusion.
yes, sir. Malignant lumpectomy.
You just say that I can't.
Most likely malignant
Yeah,
of malignant
could be like
etiology.
you got nothing in malignant except for age.
Painless lump.
Yeah, painless lump, fibroadenoma, cystosarcoma.
Yes, sir.
Very
You
Yeah,
have to keep a
take it.
differential diagnosis in this patient. You can't jump to the conclusion of it being malignant.
Right?
Yes.
Okay, next slide. Now please take over.
No. So I would disagree with him saying fibroadenoma at the age of 48, and I would still give him the benefit of
I'm
doubt.
sorry. I just
Yeah.
wanted to be
But I
telling.
think a fat necrosis can definitely be mentioned as a differential because that can happen in any individual at that age. And so you probably need to write most likely to be a malignant, or I would like to rule out a malignant cause, so that would make you more safe on
I
this.
think that's the best.
Yeah.
So
Can we move on
you
to
have
the
to rule out.
exam?
General examination, patient conscious, oriented, afemoral,
Okay,
hydrogen
stop. No, before you do this, before you start this, what is the most important thing you need to tell us? In 2024, you cannot start your exam like this.
after getting consent, like
Right?
after
No,
getting,
you have to ensure, and it is very, very important that you tell us that you attained verbal consent,
yes,
that you
actually,
examine the lady in the presence of a female attendant in a private room
yes,
with
ma'am, I mentioned
good
in the next slide,
privacy.
no.
Where? After you start your exam.
Sorry,
No,
ma'am. I
not
should have
breast.
mentioned in
It
the
is
general examination.
when you start examining when you start touching any woman,
Yes,
patient, you have to take a verbal consent before of it, and you have to have a female attendant. It's not only when you start examining some part of the body. And
yes,
you will
ma'am.
fail an exam if you don't say this in the beginning.
Yes, ma'am. Will
Yeah.
correct it.
So please
Yes, ma'am.
ensure that you say that for all patients, and then you start whatever you're. Yeah.
Yes,
Go
ma'am.
on.
After getting verbal consent from the patient in a well-lit room with a female attendant nearby, I examine the patient. The patient is conscious, oriented, afebrile, hydration is fair, moderately built and nourished. There is no pallor, icterus, cyanosis, clubbing, field edema, or generalized lymphadenopathy. The vitals were BP is 120/70 of mercury, and the pulse is 74 beats per minute, and the saturation is 99% in the An examination of breast and axilla, again
So when
mentioning
you
the
talked
concern.
about all this and you're talking about nutrition being moderate, like she's moderately nourished or whatever you said, right?
Yes,
Could you have been more specific? Because that is a factor which affects breast cancer. There is a certain measurement you could have done,
like
especially
BMI, I should have mentioned.
BMI and the waist hip ratio. So especially in premenopausal, the waist hip ratio is significantly different in Indian women. So you have to mention that. Those are important factors for, again, breast cancer risk.
Yes.
Huh? Yeah. Go on. Yeah, and like Madam said, now you're writing it like a story. If you write such a busy slide, it's very difficult to read it. You have to make it concise and crisp, right? Please continue.
An examination of right breast and axilla inspection, the patient is in sitting position with arms by side. The right breast appears to be larger in size compared to the left breast. The right nipple appears to be at lower level when compared to the opposite side. A nipple there is 1 in number, no nipple discharge, and no nipple retraction. Areola it is black in color and there is no retraction. And there is bluish contusion of size 3x2 cm present near the nipple area of a complex at 10 to 11 o'clock position with 0.5 cm scar within it in the right breast.
Baba, please talk slower. Yeah, talk slower.
Yes. Fullness is noted in the upper outer quadrant in right breast.
Can
There
you
was no
see a
lump
lump?
seen.
Can you see a lump
No.
in the breast?
No.
You can see on inspection, you can see fullness.
Yes, ma'am.
You can't say no lump seen. And this is the affected side that you're telling us about.
Yes, ma'am.
So you should always talk about the non-affected side first.
Yes, ma'am.
Yeah? Go on.
Yes. Actually, I examined inspection. I examined both the breasts simultaneously.
Yeah, so you have to tell us that the other side appears normal.
Yes.
The opposite side, axilla, both appear normal, which is important, isn't it, for staging?
Yes.
So you mention the normal side first and then go to the abnormal side.
Yes, ma'am.
Yeah, go on now. Continue. And no lump again.
Yes, ma'am. There was no dimpling, purely orange or dilated veins in right breast, no fullness in right axilla supraclavicular. And then patient in sitting.
Just wait, please wait. Go back to your slide. Go back to the previous slide. You are saying nipple 1 in number. And next line, areola black in color.
Yes, ma'am.
What are you meaning?
Nipple, there can be multiple nipples, ma'am, which can also lead to.
Frequently, do you see that? What is that called? What is the condition?
Milk line. I mean,
Milk line is the line where that occurs. What is that? If there are more than one nipples or more,
Polythelia.
what is that?
Polythelia.
Okay.
Polythelia. Yes.
Polythelia. So that is not a very common condition that you see. So you should not write nipple 1 in number. And second, what do you mean by areola black in color? Is it undergoing necrosis?
No, ma'am. She's after pregnancy, there will be change in color.
So until unless there is any positive change, I mean, that is a very subjective thing, so you should not say black in color. Here in surgery, black denotes necrosis. So I'm sure you are not meaning that, right? So both these statements are not correct. Hai na? Nipple 1 in number, areola black in color. Right?
Madam Ji, in places like KEM, where they want to lead the examiner into knowing how much they know, and if they want to talk on this, then they will say there is one nipple, and they want the examiner to ask them about.
I mean, how often has he seen polythelia? That is what I was. I had to stop him here.
We should actually take a class, ask him questions on that and see how much he knows.
So that's
Please
not
don't
correct.
mention these conditions.
Yes.
Such thing,
Huh?
don't mention these conditions or such things in the exam particularly. And that's in
Don't,
PG
yeah,
exam.
don't mention, you're wasting your own time, because the more time we ask you on this, the less we'll ask you on management. So don't say things like this. Black color, blue color, green color. It's not important. You just say normal looking areolar and nipple.
And then
That's about
further,
it.
again, madam, Shilpa madam, again, if we go
Huh.
ahead, he's saying fullness noted in right upper quadrant
Yeah,
in right breast. So right breast again and again is superfluous. You can
yeah,
just say fullness seen in upper outer quadrant and then no lump seen. So you will see only fullness, not lump. Hai na?
yeah.
You
You
will
mentioned,
not see
yeah,
lump.
you
I mean,
mentioned that. Yeah.
until unless it's a very large lump protruding involving the whole of the breast. Then, so if you have mentioned fullness, so fullness in the upper outer quadrant. That's all. That's it. Okay? Be crisp. Don't make a busy slide and actually an irritating slide. Okay, go to the next slide.
Otherwise, examiner will ask, what is lump, what is swelling, what is neoplasm? All the definition they will ask.
Yeah. And again, I think, when you're saying skin is normal, all this dimpling, puckering, pudy orange, all of that, when you're saying, now you're again asking yourself to in trouble. Like, if skin is normal, skin is normal. Let the examiner ask you what are the skin changes that are seen. Why do you want to say things and again forget a couple of things? Like you mentioned dimpling, you haven't mentioned retraction, you haven't mentioned something else. You mentioned dilated vein, you have not mentioned satellite nodules, and so then you forget a few things and then you're in trouble. So just say skin is normal around in the breast.
Yeah.
है ना?
And also when you gave a very significant history that she had pain after the biopsy, so it is very unlikely that there was no redness over the lump. There has to be redness or some signs of inflammation over the breast as she was having pain. So on inspection, you did not touch upon any of those things.
I just
And more
mentioned that she
importantly,
had a
ma'am, and Abhi, you would have seen the scar mark, which you have not mentioned on the right breast.
Yes, again,
Yeah.
yes.
I have
Whether it
written
was a sutured, whether it was a skin staple, whether the wound was dressed. So
You mentioned it. Where is it mentioned?
within the condition I have mentioned
Huh?
there is a
And you have
scar.
mentioned that bluish contusion is there.
No. You cannot get a contusion with a true cut biopsy. You will get a scar. Acha, you've mentioned here with a 0.5 centimeter. Okay. Now your slide is so busy, now it's very difficult for us to see all those words. Okay, you've mentioned it. Fine. Go on.
And patient in sitting position with arms raised above head. The right nipple is at lower level compared to the left breast. No fullness seen in inframammary area. There is no dimpling or nipple retraction. The patient is in sitting position and leaning forward. Right breast falls at a lower level compared to the left breast.
What is the interpretation of this last sentence of yours?
Actually, the patient breast parenchyma is asymmetry is there, ma'am. From
Last sentence, I'm asking the interpretation. What do you want to convey?
chest wall fixity is there or not, we can assess with that.
So, hai ki nahi? I mean, is it there or not?
No, ma'am.
No. Okay. Go ahead.
Okay.
After palpating the left breast, the right breast is palpated. It is not warm. A single lump of size 3 cross 2 centimeter present in the right upper and outer quadrant, irregular in shape, well-defined borders, uneven surface, and hard in consistency. There is tenderness present over the lump. The skin over the lump is pinchable. The lump moves along with the breast tissue. It is not fixed to the underlying muscle. It is not fixed to the chest wall. There is no nipple retraction or nipple discharge, and there is no ulcer.
what is your ruling out by not warm? What is the message behind interpretation of it is not warm?
There is no abscess or mastitis features.
There is no abscess or?
Mastitis.
Are you expecting that? Which kind of breast neoplasms may be warm?
Sarcoma.
Once you have given the provisional diagnosis of malignant, most likely malignant lump, then don't put yourself into trouble by saying not warm or inflammation, etc. Because
the
we
better
are
way
not
to see it.
expecting.
Yeah, but Abhi, there are which kind of breast malignancy will be warm?
Sarcoma can be.
No. Sarcomas are not warm.
Pagettes.
Yes.
Pages can be,
It's
IBCs can be warm. Okay, 48 is still iffy. You could have an inflammatory breast cancer.
inflammatory breast carcinoma. Yeah,
Yeah,
that's
so
right.
you can have that as well. So the thing is, when you write something on your slide or you say something, you should be able to justify it. Otherwise, there's no point saying something and then not knowing why you're saying it just because it was mentioned in books. So yes, it can be warm, and you wanted to rule out, which is very unlikely in this patient, but justify your answer.
And a better way to put it, this is local temperature not raised, rather
Yes.
than saying
Yes.
not warm,
Yes.
not cold.
Yes.
Okay,
May I come in,
local
ma'am?
temperature not raised.
May I come in, ma'am?
Please.
Look, Abhi, all this is happening because you're trying to mention what is not present. In your examination, you should say what is present, right? So if you say the skin is normal, it's normal. If you're going to say skin is dark and nipple is dark in color and there's nothing, you just say what is present. That is a better way rather than you land it up in trouble. So many questions being asked. Why? What is there? What is not there? You get me,
Yes, sir.
Abhi? Yeah.
Yes, sir.
So just mention the positive findings and very significant negative findings.
Yes, sir.
Right.
Yeah.
Also, in your next slide, another mistake is your lump is of 3 into 2 centimeter. So you have mentioned it is irregular in shape. Okay. Well-defined borders. Okay. Now, in a 3 into 2 centimeter lump, you are even getting uneven surface, which is very unlikely. If you're saying it's irregular in shape, agreed. Well-defined borders, agreed. But uneven surface in a 3 into 2 or 2, you imagine 2 into 2 centimeter, how big that lump that you can comment upon uneven surface. So it's little unlikely, right? Hard and consistency, yes.
Yes, I was able to see some raised areas in between them, so I mentioned uneven.
Which area?
While palpating, I was able to see some raised areas within that lump itself, so I mentioned it's uneven.
So that's irregular in
Nodular.
shape.
It
Or
will be
nodular,
bossulated, nodular.
bossulated, yeah.
Uneven is not making sense.
Mhm.
And this 3x2, again, all your TNM classifications only talk about the largest diameter. So this 3x2, 4x, it's not required. You just say it's 3 centimeters in its largest dimension. That is what will make your T staging. The 2
Yes,
is
ma'am.
irrelevant.
Yes, ma'am.
Lump moves along with the breast tissue. That means?
Yes.
That means?
It may be a
Intrinsic
malignant.
mobility.
Yes, ma'am. The intrinsic mobility is not present. If the
Intrinsic
lump moves
mobility
within the breast
is?
tissue or the edge slips, it can be fibroadenoma, histofadenoma.
You see for the fixity with the skin, with the underlying chest muscle, fascia, muscle, chest wall, and also with the breast tissue.
Yes, ma'am. Yes, ma'am.
So the lump can move apart from the breast tissue. You have to fix the breast
With one
and
hand
then see for the mobility of the lump, right?
Yes,
So
ma'am.
that fix. It's not getting clear whether it's fixed to the breast tissue or not.
Ma'am, it is fixed to the breast tissue.
What
Ma'am.
comprises the chest wall? What comprises the chest wall?
Ribs, serratus anterior, intercostal muscles.
Yes.
Okay. Can we move on?
Go ahead.
Examination of right axial and supraclavicular fossa. There was no lymph node palpable. And percussion, the resonant noted over the parasternal region. Examination of left breast axial and supraclavicular fossa. No lump or lymph node palpable. This is the photograph of the patient.
Left supraclav. Why left supraclav? Does it fit into the classification?
No, ma'am.
Contralateral axilla, I get. Contralateral supraclav. See, like somebody mentioned, you're talking, you're just going through the motions. You have to talk what is relevant. And all this no, and just to complete the exam, you're going to that. Makes no sense, na? For an MS, you have to be able to justify your answers. So left supraclav makes no sense. I mean, the opposite side supraclav. I don't know whether it's right. I forget, but you don't need to mention that. Yeah.
So,
And I wish you had shown us at least one picture of how you were examining the axilla and, whatever, because most times that is an issue. No, the axilla. I don't want to see so much of the breast.
yes,
Take it off. Please take this picture off. Go to the next. Do you have a picture of the axilla being examined?
no, ma'am.
So that is more important, because that's where you all guys go wrong. Yeah. Come to your diagnostics.
Case of a carcinoma right breast with pain of setting
Again,
P2N0.
carcinoma. Baba, don't say carcinoma.
Go to the previous slide. Go to the previous slide. So what possibly you can get in the respiratory system in a case of carcinoma breast?
We can get metastasis or any added on pleural effusion. We can, if there is any metastasis, we can present with pleural effusion. So
Metastasis will be in the form one of pleural effusion. Yes, correct. What else?
and nodules can be seen.
Nodules in the respiratory system. What do you mean by that?
Parenchymal deposits can blood.
Huh?
Parenchymal involvement and parenchymal involvement metastasis can occur.
Okay.
What will be the alteration in the rectal examination if patient has an Krukenberg tumor associated with it or some size? What will be the finding on the rectal examination?
You can able to palpate in the anterior mucosa.
Okay,
Any
fullness.
mass pushing fullness in the pushing.
Okay.
Or
In the pouch of Douglas.
yes,
You mentioned.
Will you-
No, I'm sorry.
You
Please
have
continue.
PV and PR both you have to mention.
Vinesh, in a male patient, if there's a cancer breast is there, if you do the PR examination, where you will feel that tumor in a male patient?
in PR you're asking, sir.
Yes.
Still anteriorly.
Hmm? Where anterior? Above the prostate or below the prostate?
Above
Above the prostate. Okay. How did you feel the spine in this patient?
so I check for any spinal tenderness in present
Where? Where did you check for the
in
tenderness?
the midline and paraspinal areas.
In the midline, there is a spine is there, isn't? So you
Yes,
palpate
yes.
of the spine.
And adjacent to it, sir.
Where? That's what I'm asking. Where do you exactly feel? Where is the first site of metastasis in the vertebra?
So in the facets,
In the
spinal vertebra facet, usually it goes.
what is pedicle of the vertebra?
So it connects.
What is pedicle of the vertebra?
The body and the spine.
And the transverse process, and a junction of that.
Transverse process. Yes.
Right. And that is the first site of metastasis. So you do not press over the spine. You press from the side of the
Adjacent.
spine to see
Yes.
further tenderness. Okay, not in the midline.
Yes, sir.
Okay. Did you examine the CNS of this patient?
No, sir, I didn't.
What findings can be there in a CNS in a patient with a cancer breast?
Patient can present with skull metastasis, skull bone metastasis. Sir. So any swelling over the head.
What will the earliest feature of the CNS metastasis in a case of CA breast? Bone metastasis you will get in the
Yes. Skull bone involvement and CNS involvement.
features of, what is that called as? Features of raised intracranial tension. So
Yes,
what are the features of raised intracranial tension?
Vomiting.
Real tension.
What examination you will do to find out whether there is a raised intracranial tension or not?
Flexion of the neck we can test.
You will use some instrument for that. What is that? To find out the papilledema.
It's a retinoscope we can use. Retinoscope we can use.
Ophthalmoscope.
Headache, vomiting, and the papilledema. Na? Those are features of the raised intracranial tension. Okay.
Why is it so important today to ask about CNS manifestations? How many percentage of CA breasts will have, CA breasts will have CNS manifestations, Abhi?
Sorry, ma'am, I don't know.
Which type of CA breasts tend to have CNS manifestations? Which kind? Hmm? I can't hear you.
Sorry, ma'am, I don't know.
Which type of CA breast tends to be metastasizing to the brain and the CNS?
I don't know, ma'am. Sorry.
You don't know. Okay. It's the HER2 positives. And 1/3 of your HER2 of your IHCs are HER2 positives, and 1/3 of them will have brain metastasis. So you have to ask for. In fact, it is now mandatory to do a retinoscopy for all patients with IHCs showing a HER2 positivity. It's a very high incidence of silent CNS metastasis before it actually becomes, presence with ICT. So all patients with HER2 mets ideally should have a MRI brain as a protocol. Yeah, so it's a very high incidence. So you should not have missed that on your systemic exam. Okay.
Which bones can be involved or have metastasis in CA breast? Which bones are likely to be involved? Which bones are likely to be involved?
Lumbar vertebra, femur.
Femur.
Yes, correct. Lumbar.
Lumbar, femur,
Then
and ribs.
Usually flat bones are involved.
Flat
Femur
bones.
is not involved.
neck of femur.
Neck of femur.
Which is the other common bone?
Skull bone can be involved.
Flat bones.
Thoracic vertebrae. Then ribs. And then skull.
Yes.
That's the order of likelihood of involvement. Lumbar vertebrae, neck of femur, thoracic vertebrae, skull. Okay?
Yes.
Okay. Go ahead. Next slide, Avi.
Diagnosis. A case of carcinoma right breast with TNF staging T2, M0, M0. Stage 2.
What is the average size of the lymph node so that you are able to palpate the axillary node clinically? What should be the average size of the lymph?
2 centimeters.
Even less than that. Even less than that.
One.
Okay.
I think it depends on so many factors. It depends on the obesity of the patient. It depends on the axillary fat. So from 0.5 centimeters onwards in a very thin patient, yes. But a lot of times, so it just depends on your skills. I think as Anjali will be probably able to find a 0.5 centimeter lymph node. And, so it just depends also on the clinical skills and all. But yeah, from 0.5 onwards, you can in a thin individual. And in a very obese individual, you may not be able to find at all central groups. So I guess.
Right.
Okay, let's move on to management. I think we're hitting time. It's like 10 minutes left. So tell us the management protocols, Abhi.
I'll complete my triple assessment. I've done the clinical examination. So I will further proceed with mammogram, ultrasound breast and axilla. And for pathological confirmation, I will do image guided core needle biopsy. To assess the stage, I will
It has
do
already
ultrasound.
been done, na?
Yeah,
Yes,
it's
ma'am.
already been done, right? Yeah.
Yeah.
And for staging, I'll do ultrasound abdomen, pelvis, X-ray, spine, skull, and chest. And for regarding fitness for anesthesia, I'll do routine blood investigation and ECG and echo.
No blood investigations in your staging process?
I will do LFTs to look for alkaline phosphatase to look
Yeah.
for any bone.
Yeah. So you have to mention it, no?
Yes, ma'am.
And it's not fitness for surgery, it could be fitness for management. A lot of times we'll give them other management protocols. So this fitness for surgery should not come into your basic investigations. Okay. So tell us now, Anjali or ma'am, would you like to give him a working diagnostics on the IHC so he can tell us the management?
Okay. So this patient of yours is clinically T2 N0, no,
Yeah,
N1. What was it?
N0.
N1,
N0, N0.
N0.
N0,
N0.
T2 N0, M0. So it is which carcinoma? Early, locally advanced, late, what?
Early breast
Falling into
cancer.
which category?
Early breast cancer.
Early breast cancer, right?
But
Right.
when we
So
are
you,
sorry, ma'am, when you are saying T2,
yes, yes.
but in your mobility test or chest wall fixity, it was positive, na? That retraction test was positive. So tumor on your clinical examination, it was adherent, na?
Yes, ma'am. It was
As
fixed to the
compared,
breast tissue.
yeah,
To the breast
yeah.
tissue.
So
not
here
to-
yeah,
To
it
the
may
breast.
not be T2, okay, but
Yeah, so
yes,
okay.
madam, go ahead.
So let's just give you a picture. So this IHC's come triple positive. How will you manage this patient?
I will do breast conservative surgery. I'll give the patient an option now. So whether to go with breast conservative surgery and following radiotherapy, or she may opt for modified radical mastectomy.
No, but she may opt for anything. Would not the size of the patient's breast, would not other factors also come into play when you're advising breast cancer, conservation surgery, BCS? What are the criteria
What are the
fulfilling?
prerequisites you will
Yeah.
keep in mind before you advise the patient BCS? What are the prerequisites that you will keep in mind, and what else will you do to that you are that you may be able to do breast conservation surgery?
Here, madam has given you an option that all IHC are positive, ERP are positive, and even HER2 is positive, na, ma'am?
Yeah, all triple positive, yes.
Yeah,
And
yeah.
and the
So
reason,
triple positive.
Anjali,
can-
when examiners ask questions like this, now the candidate should take hint. When I'm saying it's triple positive, he should not have mentioned surgery first,
Neoadjuvant,
Yes.
madam.
So you
right?
should think what is it a positive indicator or a negative indicator?
That's a positive thing. I
How?
would go with neoadjuvant chemotherapy.
Why,
Neoadjuvant
why,
systemic therapy, ma'am.
why would you consider neoadjuvant in a triple positive and not other breast cancers?
Because there is hormone therapy we can provide, ma'am. So we
No,
can downside.
that so I can give NACT hormonal also. But triple positives especially would ideally require some, it's NCCN guidelines would mention that, yes, you need to give NACT to triple positives. So what is the thing that you need to give? So
If at
there
all
is
planning neoadjuvant,
there are
what
emerging
are
guidelines.
the
There are emerging guidelines which say that if you give trastuzumab NACT, the the OS and this thing is kind of almost coming into significance. So there is a role of NACT in triple positives.
Sorry, ma'am, madam.
Yeah. And what are the local contraindications for BCS and what are the systemic contraindications for BCS?
There is any multicentric disease we
Okay.
can't provide
Which is multicentric? Which kind of breast cancer is multicentric? And if you don't know, na, Abhi, say you don't know, so we can move on to the next question.
I don't know.
Lobular cancers.
Yes.
Right?
Yes.
Okay.
Yes.
Next, local contradiction. Most important local contradiction.
If it is fixed to chest.
Huh?
If it is fixed to chest wall.
No. Then
What
it
is
does,
the tumor breast ratio?
that is
Tumor
not
and breast ratio. It or not?
If it is more than 20%, we can't.
Yeah. So 25%. Of course, again, now you have so many other options available in terms of what can you do to reconstruct the breast. But usually, yeah, it doesn't make much of this thing. So you have to consider all those factors before you just go and say that, yes, BCS is an option. Then you should know about oncoplasty and you should know about all the flaps that you can use. Yeah? Okay, so now this is triple positive. Tell me, what will you do? How will you manage her?
Neoadjuvant trastuzumab, as you mentioned.
Along with trastuzumab, what do you need to give neoadjuvant? Can you give it by itself in a neoadjuvant setting?
Sorry, ma'am, I don't know.
Before Abhi, before you start with the neoadjuvant chemotherapy, how will you know whether your chemotherapy is responding or not responding? So before chemotherapy, what measures you will take so that you will be having some parameter whether it's responding or not responding? What is the scale with you? What will you do to the tumor?
Yeah, you said something. Say it loudly and clearly, na?
Through RECIST criteria, we can assess that.
What's the full form?
Response evaluation of solid.
Okay, are you aware of the criteria?
Yes, ma'am. Like after 2 cycles or 3 weeks, we have to reassess the patient whether the lump has disappeared or if there is any increase in size or
there is a percentage reduction, no? 20%, 40%, what is it?
Yes, ma'am. If it is completely responsive, there will be no lump palpable in the next assessment. If it is partial response, that is less than 30% reduction in size.
So you have to, and the other thing that, sometimes these lumps can completely disappear. So is there something you can do around?
Previously, we have to use any silicone tips or metal clips to the lump inside the tumor.
Yeah, you should mention that before starting any NAC, that you should clip the tumor and you should use the RECIST criteria too. And to the question I asked, along with trastuzumab, you usually need to give taxanes in the NACT setting. Yeah. So, okay, you've given that, the tumor has become now 1 centimeter. Now what are you going to do?
I will proceed with breast conservation.
If it fits in the criteria, you do breast conservation. What does it include?
I mean, it includes wide local excision of the primary tumor. Then, if there is any axillary lymph node, we will proceed with axillary dissection. In this case, I don't have any axillary lymph node, so I will do sentinel lymph node biopsy. And following that, we'll give a radiotherapy.
So sentinel lymph node biopsy, if you don't really have the wherewithal, the dyes and everything else that's coming, what else can you do?
I'll do
What is
axillary dissection.
No, you don't go and do axillary dissection if it's completely negative. What else can you do? An alternative to sentinel. Have you heard of axillary mapping?
Sorry, ma'am?
Axillary mapping?
No.
Yeah,
What
Anjali
is
was
targeted dissection? How it is different from the sentinel node biopsy? One is sentinel node. How many nodes are removed in the sentinel node? Two more than two, isn't it? Then what is targeted axillary dissection? By which we will have a idea upon which that which nodes are positive. So according to that, we will take out only the targeted nodes. That is called as targeted axillary dissection. Okay, depending upon the blue dye test. Okay, and complete axillary dissection is you are removing micro positive and macro positive, both, even negative also at times. So that is complete. So there are pros and cons of each, isn't it? So
Yes.
sentinel node is for a tumor which has completely disappeared. That is one. And if in initial examination it is 1.5 or 1 centimeter, okay, then targeted dissection is completely, if it is responding to your chemotherapy, you will definitely go for the minimalism so that she will not have the lymphedema, etc., etc. Yes, ma'am. Shilpa, ma'am.
No, let him continue. So no, the only other thing is like in a lot of places we don't have ICGs and we don't have your this thing. So we can do an axillary mapping which involves removing. So it's around the second intercostal nerve. Below that, the area that's 1A. So that group of lymph nodes is taken and sent for axillary for a frozen section. And if any of those lymph nodes come positive, then you complete the axillary dissection, or then you just leave it at that. So that's got a very high sensitivity and a high specificity rate. So in areas where you do not have the facilities for the dye test or ICG, you can do an axillary mapping. It's a faster, easier process. So you do that. So that's the bare minimum you need to do. So the nodes are negative. You've sent the tumor. When you're doing a BCS and you do a wide local excision, what else can you do to confirm that you've taken out enough?
Like frozen section we can do on table.
Do a frozen. How much is the diameter? How much is the free margin that is now expected?
1 centimeter.
1 centimeter. Okay, so you've done all this. Patient's undergone surgery. Now what?
And I will check with the biopsy report.
Yeah,
If there
it's
is any
IDC triple positive. Now what will you do?
completion radiotherapy of the given.
Okay, you don't want to give chemotherapy to this patient.
That's
3 centimeter lump. You don't want to give chemotherapy.
yes, ma'am. We should give more than 1 centimeter lump. We have to give chemotherapy.
Yeah, so you will
Adjuvant
give, no?
chemotherapy should be given.
So what chemotherapy?
Cyclophosphamide, adriamycin, and 5-fluorouracil.
I'm sorry?
Cyclophosphamide, adriamycin, and 5-fluorouracil.
So it's called anthracycline-based chemotherapy, and we don't give 5-FU anymore. So anthracycline-based and taxane-based, right? And you will give both. And she's triple positive. So what else? And she's
trastuzumab we can do.
And she's triple positive. So she's also ER/PR positive. She's perimenopausal. What will you do?
Tamoxifen we can.
So
How long will you give tamoxifen?
No. So
Dose
how
and
will you decide?
duration.
How will you decide whether you're going to give tamoxifen or you're going to give an AI? In a perimenopausal
in a
woman.
perimenopausal, I mean, as
But
she
she's
is
still
attaining her
menstruating.
menopausal, we can go with aromatase.
No. How will you confirm you said she menstruated a month back, right?
Yes, ma'am, but it's reduced
So how will you
duration, slow.
confirm? What is the test you will do to confirm? So you can do the serum estradiol levels and the FSH levels, which will tell you whether the patient is actually perimenopausal, premenopausal, postmenopausal. So if she is perimenopausal, she still has a premenopausal thing, you will give tamoxifen, right?
Yes.
And then you can convert later on. If you have to continue with tamoxifen, how many years?
10 years.
What are the side effects?
Yes, nowadays it is still.
Hot vomiting, hot flushes, risk of endometrial carcinoma. She can experience vomiting, hot flushes, headache, and there is a risk of endometrial carcinoma.
Thromboembolic phenomena?
Yes.
Those are the more dangerous ones, no? The thromboembolic and the endometrial cancer. So how will you check the patient after that? Like what follow-up?
Through ultrasound, basically we can
How
do
often,
the ultrasound.
how often do you need to do an ultrasound?
I don't know.
Every year? And then
Okay.
what happens to the trastuzumab? Do you continue it or not?
Yes, ma'am, we continue with the
For
trastuzumab.
how long?
If ultrasound is inconsistent, we'll continue till 10 years.
Huh?
10 years, ma'am.
10 years trastuzumab?
As well, tamoxifen.
1 year. Okay, my last question. What is the role of bisphosphonates in this patient?
It will improve the bone density, bone mineral density, ma'am.
It is recommended
giving...
that you give bisphosphonates to all patients who are ER/PR positive, right? Okay, I'm done with my question. I think I've asked enough. So Anjali and everybody else who wants to take over.
Yeah,
Why do you give the multimodality treatment for a cancer breast? No, there's a small breast cancer is there, but still you want trying for everything in this. What is the reason for that?
The main reason is to
You know what are the various theories of the spread of breast cancer?
Sir?
What is the Holstedian concept? What is the Fisherian concept? What is the spectral concept? You have any idea about that?
No, sir.
Holstedian concept, you know, when it started with the Halsted, he said everything is loco-regional. And that is why he used to excise everything. Even the Halsted mastectomy was done. And then the Fisher said, no, it is a disease right from the day one. It is a systemic disease. So that is why all those chemotherapy they came. And then the people started looking into that. No, it is both. It is loco-regional as well as systemic. And that is a spectrum concept which is there. And that is why you try all these multimodality treatments for a patient with breast cancer. You know how much time does it take to become a palpable 1 centimeter lesion in a breast cancer?
6 years, sir.
How much time does it take,
sir,
to have a 1 centimeter palpable lesion?
1 year, 6 months.
6 months, some cycles.
Have you heard of the tumor doubling time? What is tumor doubling time? So it is based on that tumor doubling time. Approximate tumor doubling time in the breast cancer is around 100 days. And it takes at least 5 years, okay, not 6 months or 1 year, 5 years to have one cell converting into 2 and 2 into 4, 4 into 8. It requires a 30 doublings. And that 30 doublings is there, which will take around 5 years. So when you are palpating that 1 centimeter tumor, you are thinking it's a very early cancer. Still, it is there for 5 years. And it is said that even in the 23rd doubling, though it is still not a centimeter palpable tumor, it can metastasize. And that is why the Fisher concept was there. Okay, so all these multimodality treatment which is there is based on this concept.
Yeah, and I think also screening, which is not happening here, but screening is pretty much in the Western or in the European setup. It's really helped improve this thing because screening catches it when it's like 1 millimeter or 0.5 millimeters, which is why they're doing, you know, so that's the other this thing that why we are pushing screening so much for breast cancers.
Yeah, that's right. Yeah, that's right. Yeah. Okay.
I think Dr. Kanagavel is already saying that we finished our time.
Yeah. Yeah.
So I think Abhi, if you have any questions that you want to ask of us before you go off, this is your time.
No, actually, I
Any
could prepare more.
doubts? Huh?
Like I have still doubts in presenting the sheets now. Like whether I have to be so elaborate or real minimalistic. That's all. I'll
No,
just improve
you
my.
have to find a middle path. You cannot be either or. You have to find a middle path. Like we mentioned, you don't have to keep saying no, 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 no. I think somebody mentioned, and it's a very
I
good
had
this
no
thing.
positive findings in the patient, so that's why
Yes, but
I
you can
mentioned.
still say, like, like when you said there is no warmth, you can say local
Yes,
temperature
sir.
is
Here
normal.
to Shiva, sir.
You
Then
can
I
say a
will
lot of
update
other
what is
things.
happening from this.
So you have to say that in your thing, and you can say very broadly that there are no evidence of metastasis in these systems. Don't just because you don't have something, you don't have to invent something. Okay. Yes.
You have done well,
Yes, Sarji.
Abhi. You have
You're telling us to now keep quiet and shut off.
No, man.
Okay. Anything else you want to ask, Abhi, before we end this thing?
No.
Your history was good. Your knowledge is good. You need to make it a little more patient oriented. It cannot be textbook oriented. It has to be, every patient has a specific number of things that you need to ask or not ask. So you in an MS, that's what you need to learn from an MBBS setup. So I'm sure you
You
will
could
get that as
improve
you
upon your
practice.
slides also, Yeah.
Yeah.
You could improve, 6 lines. Don't make very busy slides. So a good PPT is you make 6 lines, 6 words. So don't make busy slides, right?
Yes, ma'am.
Yeah, absolutely. Yeah, it's like we feel giddy looking at all those things. But you did an
And
overall, I think, good job.
may I just say something, ma'am?
Please go ahead.
In this slide, it says to confirm diagnosis mammogram. Mammogram is not a confirmation, right? Just
To
delete it.
confirm,
The
yeah,
only
yeah,
confirmatory is just remove
yeah,
that.
yeah.
Mammo is just
Yes.
what is mammo is it is just aiding to find out if there are impalpable lumps in other breast or in other portions of the breast. It doesn't come to help you make a diagnosis. Okay, so just do away with that.
I think the radiologist may not agree, but
I mean, ma'am,
yeah,
it is pathology. It's a pathological
yeah, it's a
specimen which
pathological
diagnosis.
diagnosis, but it's essentially to confirm like we have the
Yeah,
BIRAGs
just
and everything that you need to know.
right,
Yeah,
right.
right. Yeah,
One a piece of evidence.
absolutely. Yeah. Okay,
So,
so I think Dr.
Yes.
Kanagawa, can we
So
yes.
Abhi,
can we
one
take
No,
off?
no,
last
ma'am.
comment,
I'm
Dr.
fine.
Shilpa.
Yes, ma'am. Thank you.
Thank you for all for joining this week, being the last class for the year. And this next year, we are going to try modifying some changes. And it's going to be all on Fridays and 8 o'clock. The format will be a little faster. That's what has been repeatedly asked by some of the students. So with the permission of the faculty, now we move on to the second case.
Dr.
Shilpa ma'am,
Kanagawa,
are you
before I
running to
go off,
something or can you stay back?
no, I need to move out.
Correct.
But let me take this opportunity for being very impressed with your enthusiasm and your amazing ability to conduct this thing. I am very impressed.
Thank you so much, ma'am. All like
Consistency.
everyone has contributed, ma'am. It's not credit to me.
Yeah, but
It's credit
chasing
to
all of us
every
is
one
not
of the students.
easy. Chasing all of us is not easy, and you've been doing a wonderful job. I think
Thank
you
you, ma'am.
have the hearts and this thing of all those postgraduate students who are very happy with this.
Thank you, ma'am. Thank you very much. Thank you.
I take your leave. Thank you so
Yes,
much.
ma'am. Good night, ma'am. Happy New Year to you and all of you at KM.
Yes, thank you so much.
Bye-bye.
Good night, Dr. Shilpa.
Thank you.
Good night. Good night.
Thank you.
So with the permission of the faculty, now we move on to the next case. This is kindly contributed by Professor Hemant Natyal, sir. Dr. Hashir Shakil will be presenting a case on peripheral artery disease. Dr. Hashir, please introduce yourself. You are unit chief and head of the department.
Yes,
And go ahead with the
a very good evening to all the respected faculties. I am Dr. Hashif from Himalayan Institute of Medical Science, working as a resident general surgery department. My head is Professor and head Dr. Hemant Kumar Nautiyal, and I would like to thank him for this wonderful opportunity, ma'am. Hello.
Go on, go on.
Yes, sir.
Dr.
Can I
Shakil.
start?
Yeah, please.
Sir, I would be presenting a case of a 65-year male resident of Teri, Uttarakhand, driver by occupation. The patient presented to OPD with pain in left lower limb for 4 months, blackish discoloration of left foot little toe for 2 months, followed by blackening of right little toe for 1.5 months, and ulceration over left foot for 1.5 months. History of presenting illness. Patient was apparently well 4 months back when he started feeling pain in left lower limb, which was intermittent in character, severe intensity and cramping in nature, localized to left lower limb, more in the calf region, associated with walking. Earlier, he could walk for more than 200 meters, which gradually reduced to few steps over past 1 month, and now complain of pain at rest since 10 days, which was severe intensity and continuous aching in nature, and patient has to stop for relief. The pain aggravates on lying down and is relieved by hanging his leg by side of the bed. The pain was more at night. The pain was associated with blackish discoloration of left toe since 2 months, followed by blackish discoloration of right little toe, which was spontaneous and gradual. Patient also noticed an ulceration over lateral aspect of left foot 1.5 months back following an trivial injury to heel. So the ulceration later had pain in it and foul smelling discharge. So the patient has no history of fever, chest pain, shortness of breath, palpitation, any blackouts, altered sensorium, blurring of vision, diplopia, pain abdomen, pain in lower backs and buttock, impotence, or no history of claudication or pain in right lower limb, right side. Some medical history. Patient is a known case of hypertension since 4 years on irregular medication. Patient used to have amlod 5 mg for few in the starting of his treatment but has stopped. Patient is a recently diagnosed case of type 2 diabetic mellitus. No history of pulmonary TB, COPD. No history of other chronic drug intake, sir. Surgical history. The patient underwent debridement of the left foot ulcer at a local hospital in November 2024, underwent raised amputation of little toe and debridement of ulcer over lateral malleolus on 6th December. Patient again underwent debridement of left foot ulcer on 9th December. Personal history. The patient is a non-vegetarian by diet. He's a chronic smoker since 40 years. He's smoking 20 BDs a day, that is 1 pack, and his 40 pack years. History of alcohol consumption for 30 years, approx 350 ml for 4 to 5 days a week. No history of tobacco chewing. Patient has a history of disturbed sleep due to pain, and he has a normal bowel and bladder habits. So in family history, there's no history of hypertension, coronary artery disease, or stroke or type 2 DM in family. So summary, 70-year-old gentleman, BD smoker for 40 years, known case of hypertension for 4 years and a newly diagnosed case of diabetes mellitus, presented with complaint of intermittent claudication since 4 months, which now progressed to wrist pain. There is history of blackish discoloration of bilateral little toe and non-healing ulcer with foul-smelling discharge over left foot for past 1.5 months. So the patient had 5th digit raised amputation and multiple debridements. Sir?
Yeah, Dr. Shakil.
Yes,
First
sir.
thing, your patient has grown by 5 years from the time you started taking the history, and then you given your summary. You started how many years? What was his age in the first slide?
Sir, age?
Yeah,
So,
just go to the age
sorry, sir.
first.
It's 65 actually, sir. Yeah, it's somewhere 70. So 65. Sorry, sir. It's 65.
Yeah. So
Okay.
I thought your patient grew
No,
by 5 years during your taking
no, sir.
history. Okay.
Sorry, sir. It's
Okay.
just
No,
typical
it's okay.
typing
It's
it.
okay. I'm just joking. I'm just joking.
Yes,
I
sir.
know.
Sure, sir.
Look, it's a whole jumble. I'm not getting the sense. Left toe, right toe, one debridement, left debridement, one amputation, other amputation. You have to give me a sequence, right?
So the sequence was that the patient first had pain in the left foot 4 months back, which was followed by blackish discoloration in the
But
left
there's no
toe
pain
since.
on the right limb. There's no pain on the right limb and still is having
No, sir.
amputation.
No, sir. No pain, sir. No pain in right limb. That has written in negative history, sir. Koi pain, sir. No claudication, no pain was there in right limb.
Okay. And 200 meters is not much.
Yes, sir.
You can't say 200 walking around 200 meters, which is normal, right? So that's it. Obviously, this is a case of diabetic foot, right?
Yes, sir. It's
So, right. So, I mean, instead of you telling me about diabetes in medical history, I would like it to come right up front,
okay, sir.
right? That this guy is having ulcers with a history of recently diagnosed diabetes, and then go
Yes,
on,
sir.
right?
Okay, sir.
Please, anyone else? Okay, so what's your diagnosis now? Okay, one more thing I
So,
want to say. Sorry, Dr. Shakil, let's go to
yes, sir.
your negative history. You gave me a whole negative history about global arteriosclerosis. That is not required.
Yes, sir.
That's not required.
Sir, okay, sir.
Right.
But sir, the patient has blackish discoloration and decreased cold limbs, so that why, sir, I was looking
So you
to
just
rule
say
out
that
all. Okay, sir.
there's no complaints suggestive of global involvement of the vessels by
Okay, sir.
arteriosclerosis.
Sure, sir.
Okay. Should we go to the examination then, sir? So what's the diagnosis? Let's compare. What's the diagnosis now?
So by now I have a two differential diagnosis. It could be a sir, ischemic disease. The cause could be arterial or venous as of now, and sir,
Why venous?
diabetic.
Why venous? Hang on, Dr. Shakil. Why
Yes,
venous?
sir.
Why venous?
Uh,
Why not neurological then?
so in
Why not
neurological,
neuro?
it is painless.
So why venous then?
So as of now, sir, I haven't
No,
examined it.
as
So
of
it
now.
could
No,
be,
no.
sir.
You cannot put it as of now. As of now, why? Tell me, why do you think it's
Oh,
venous?
sir, then, sir, it's arterial, sir. I would be sticking with sir arterial
You
cause.
just say, yeah. Just say that
Yes, sir.
it is. So what's the diagnosis?
So, it's arterial ulcer disease, sir.
No, that's not a diagnosis.
Uh,
It's a diabetic
sir,
foot.
I could,
Come straight away,
yes,
diabetic foot. It's a
diabetic foot,
diabetic foot.
sir. Yes,
He may be diagnosed recently. Could be having diabetes since long, not been diagnosed,
sure, sir.
right? So what is most obvious? It's a diabetic foot. So anyone else?
Yes.
Hello.
Yes,
Shakil,
sir.
what is claudication?
Sir, claudication is when the patient sir, after having a walk of a certain distance, the patient starts feeling pain, and this pain is a sir, crampy pain and reproducible pain, and it after on taking rest, it subsides, sir.
What is rest pain?
Sir, rest pain is, sir, it's basically dying muscles when they demand for oxygen and there's less adequate oxygen supply, sir. So the dying muscles का sir rest pain होता है, sir.
How it is classically described, rest pain?
So, so adequate, sir, the pain which is present even on rest, sir, it's just the dying muscles का sir होता है
Dying
seen in
muscle or
chronic wound
dying
ischemia.
nerves?
Sir, dying
Crying
nerves,
out
sir.
dying nerves.
Dying, crying of dying nerves, sir.
Where we will get
No,
the
hang
rest
on.
pain?
Dr. Shakil. Dr.
Yes,
Shakil.
sir.
What are the causes
Yes,
of
sir.
pain in peripheral arterial disease now? It is just the nerves, nothing else.
Sir,
Sir,
it's arterial ulcer, sir.
What are the causes of pain in peripheral arterial disease now? It is just the nerves, nothing else.
Sir, one of the cause is, sir, the nerves, and sir, it's
That we've
the,
discussed.
yes, sir.
That is fine. You said nerves. Anything else?
So
Is it
one is,
related with the ischemia? Is it related with the
yes, sir.
ischemia?
Yes, ma'am. It's related with ischemia, sir, ma'am.
Ischemia of what?
Ischemia of
Ischemia of tissue, sir.
Yes, of muscles. There's
Yes,
decreased blood
yes, sir.
supply.
Ischemia of muscle. Yes, sir. Ischemia of muscles and tissues, sir.
So it's just
Decreased
not
blood
nerves.
supply.
Look,
Yes,
cry
sir.
of the dying nerves is typically denoting in TAO or kind of things in Burgess, because it's a neurovascular bundle which is being involved there, right? That's why you get more pain there.
Yes, sir.
In diabetes, the pain is not because of the nerves. There is ischemia of nerves, but there's ischemia of muscles also,
Yes, sir.
right?
So shall I move forward?
Yeah, please do. Examination.
So on general physical examination, patient was examined in a well-lit room with proper exposure after taking full informed consent. Patient is sitting by edge of bed with his legs hanging below level of bed. So patient was conscious, oriented, cooperative to time, place, and person. The patient was moderately built and nourished, weighing 68 kg, height 172 centimeter, BMI was around 23 kg per meter square. So on general physical examination, on vitals, the pulse rate was 84 beats per minute. It right radial artery, regular rhythm, normal vessel, normal, no radiofemoral delay, conditions of vessel wall normal. So this remaining pulses examination has been discussed under local examination. BP was 134 by 80 millimercury, right arm sitting posture. Respiratory rate was 18 per minute and temperature was 98 Fahrenheit. So pallor was present. No sign of icterus, cyanosis, clubbing, lymphadenopathy and fetal edema seen. Adequate hydration was there, sir. So examination of lower limb. So shall I go with the examination?
Yeah, please finish.
So inspection of the left lower limb, amputated left fifth digit, and approximate 6 into 4 ulcer seen over lateral aspect of foot
Dr.
on the
Shakil,
dot.
Dr. Shakil, I got to stop you here. You
Yes,
can't
sir.
just jump to the ulcer straight away.
Okay, sir.
You've got to examine the two limbs as a whole, and then come focus down to the ulcer. You can't go from from inside to outside. You have to go from outside to inside. Do you get me?
Sure.
Yeah,
Sure,
please do
sir.
that.
So on inspection, there is no engorged vein or dilated veins are seen. So there is no color
No.
change
Okay,
of the foot.
Dr. Shakil,
Yes.
you continue with this.
Yes.
We'll sort this out as we go along. Continue with this.
So an approximately 6 into 4 centimeter ulcer over lateral aspect of foot on the dorsal aspect with visible tendons and base. An approximate 6 into 4 centimeter ulcer seen over lateral malleolus and over tendons and bones exposed. An approximate 3 into 3 centimeter ulcer over lateral aspect of heel with necrotic margins. There was no discharge. On the inspection of left lower limb, pulp of toes flattened. There was shiny skin, nails, transverse ridges, and brittle nails were present. Loss of hair and subcutaneous fat over leg and foot. No gross deformity in attitude of left lower limb. Muscle wasting present, sir. No dilated veins. So actually, I put this in front. I have to put it in the front slide, sir. This one.
Okay, go on.
Examine inspection of right lower limb. So in the right lower limb, all the inspection findings were normal except the gangrenous fifth digit line of demarcation present, area adjacent to two is tender, shiny skin, transverse ridges were present, loss of hair and subcutaneous fat over leg and foot, no gross deformity is seen, sir. Muscle wasting present with no dilated veins, sir. So on palpation, cold bilateral extremity up to knee joint, tenderness present over the foot and ankle joint more at distal aspect, The capillary refill time was more than 10 seconds. There was no crepitus or edema present, no thrill. So now the peripheral pulses examination. So on peripheral pulses examination, when left lower limb was palpated, so the dorsalis pedis artery, anterior tibial artery, and posterior tibial artery pulses were not palpable. While on the right side, the dorsalis pedis, anterior tibial, and posterior tibial was feebly present, sir. Rest of the peripheral pulses, that is the popliteal artery, femoral artery, radial artery, brachial artery, was palpable, sir. Palpation, movement of joints at intertarsal, mid-tarsal, ankle joint, knee, and hip joint present. Active toe movement present except right fifth toe. Motor examination, tone normal, power of the muscles normal. So the bulk of the calf muscles in the right and left both limb was reduced. So there was hyperesthesia of left foot present. Crude touch and fine touch, temperature, pain, sensitivity above ankle was normal. So on auscultation, there were no blue heard over brachial, femoral, or popliteal artery, sir. So other systemic examination, chest, bilateral air entry reduced, no added sounds. Left fifth intercostal space. Sir, on CVS examination, apex beat was present at fifth intercostal space and mid clavicular line. S1, S2 heard. Abdomen soft, non-distended, non-tender. On CNS examination, sir, higher mental functions intact, no sensory or motor deficit. So thank you, sir. This is the my examination, sir.
Okay, Dr. Shakil, there are
Yes,
some
sir.
things which I want to tell you before we start. Look,
Yes, sir.
You have to, by your history, prove that it's an arterial case
Yes, sir.
and not a venous or a neurological case. Hello.
Hello,
ये
sir.
iPhone
Yes,
7
sir.
प्लीज बंद करें अपने आप को. iPhone 7 प्लीज. Okay, right?
Yes,
Now,
sir.
when you start off your inspection, let's go to your first slide.
तुम सबके पास काम करके आओ लास्ट मेरे पास ठीक मैं आपको काम दे दूंगा.
ये iPhone 7 प्लीज कौन है?
कहता था कि जब मैं कर
Yes,
रहा
sir.
था तो मेरे जितने
iPhone 7
टीचर्स थे, प्रोफेसर थे, लीडर्स, तो मुझे काम देते थे. उसका मेरे 14 लैपटॉप
iPhone 7
भी
needs to
एक
be
दिन में.
muted. Who is iPhone 7?
Okay, let's go to your first
Yes,
general
sir.
examination.
Yes, sir.
You say there's no pedal edema. Do you think this, with so much of infection and ulceration, there'll be no pedal edema?
Sir, but in this patient, there was no sir, the pedial edema which could be.
So there's a difference
Sir.
between pitting edema and non-pitting edema, right?
Yes, sir. Yes, sir. But
So
they
what is the difference? What is the difference? There could be there could be no pitting edema, and I don't expect this patient to have pitting edema.
pitting edema, sir. He might have, sir, normal non-pitting edema, but sir,
He will have a non-pitting
yes.
edema.
Okay,
Now, what is
sir.
the difference between the two? What is the difference between the two?
So in normally, sir, pitting edema is basically seen when there is lymphatics involvement, or sir, if this patient is having CKD or sir cardiac involvement, sir, the fluid collection is present, sir.
Right. And what is non-pitting?
So non-pitting edema is mostly seen in cellulitis or sir in
When it is associated with inflammation.
Yes, sir. Yes, sir. Inflammation.
Okay. So you think this patient is you can't write no pitting pedal edema.
Oh,
He must be
sure,
having
sir.
non-pitting.
He must have some degree of G, sir.
Right. Next slide. Now every human has got two limbs, right?
Yes,
two
sir.
lower limbs, two upper limbs, 2 ears, two eyes. You got to compare the two first. The length,
Okay, sir.
the girth, the color, the integumentary system, right?
Sure, sir. I'll take into this account, sir, in my next.
Right. Next slide. Okay, we'll discuss all this later on. Next slide, please. Okay, about you said something of movement of joints. It is not the movement of joints, but the range of movement.
The
ROM
range
of the
of
joint, which is important, right?
which got
Also,
affected. Okay, sir.
right, when you're testing for sensory, the joint position has to be tested, right?
Yes,
Whether the patient can appreciate the position of the joint. So if you move the limb up and ask him whether he knows without saying whether the toe is up or down, right? So that
sure,
is
sir.
important rather than just range of movement. Okay. Next slide. No crepitus. Why are you looking for crepitus? Also, where are you looking for crepitus?
So,
Where are you looking for crepitus? In the upper limb? On the forehead?
no, sir.
Where?
So, crepitus is basically seen sir, arteries like sir.
No. Your patient is having a pulse rate of 670 and his BP, everything is normal. Why are you
Yes,
looking for
sir.
crepitus? What are you looking
Not
for?
needed in this case, sir.
Is it gas
Just to
gangrene? Is this
no,
gas
sir.
gangrene?
Not
Is
no,
it?
sir. Yes, sir.
No.
To just rule out, it's not needed in
No.
this case, sir.
Look, Dr. Shakil, what I want
Yes,
to say that in examination, do say whatever you do in your wards. If you try
sure, sir.
to put in more things, you'll end up in trouble.
Sure,
Okay?
sir.
No thrill where? Where are you looking for thrill?
So basically, only vessels or arteries, if there's throbbing pulsation
Yeah.
or something
Where?
like this.
Which vessel? Which vessel? Which vessel do you think is involved here?
So popliteal or so popliteal.
Look, you're not getting pulses where from where to where. Which pulse is absent?
So in left foot it was dorsalis pedis and distal posterior anterior tibial that was absent, sir.
Right. So the pulses above that are present,
Yes, sir.
right? Why do you get a thrill?
So if there's any aneurysm or something present, then we'll look for thrill, sir.
No, it's just aneurysm. What is a thrill and what is a bruit?
So
What is the thrill?
Brew is sir auscultatory finding which we heard
Right, very good.
like we
Very good.
carotid. Yes,
Very
sir.
good. Now,
Yes, sir.
all this
Yes.
happens if either the
Yeah.
flow is increased
Or
or the
if
vessel
the
is narrowed. Vessel is
narrowed,
narrowed,
sir.
right? So where
Yes,
do you
sir.
think the vessel is narrowed here?
So at the level of sir popliteal region, sir.
Very good. So you tell me that you look for thrill
Yeah.
at popliteal region and above that.
Sure, sir.
Okay, next
Yes.
slide. CRT is not important. Look, I just wanted CRT is greater than 10. If you have already got an ulcer, obviously
Sir.
the compromised. So CRT is not
Yes,
important
sir.
here now. Right. Next
Okay,
slide.
sir.
Okay, next slide. Movement was just like I told you, range of movement should
Yes,
be
sir.
there.
Range of
Active toe
motion.
movement, right.
Sure.
Active toe, okay, motor examination. Next slide. I read your slide somewhere where you said the pulp of the toes is flattened.
Yes, sir.
Did you write that somewhere?
Yes, sir.
No, what do you think is happening there? Why is it flattened?
Sir, pulp is flattened because of sir hyperesthesia. Something patient is getting
No.
no, sir,
What is
because
the
of a decreased blood supply to the tip of
now?
the
What is the deformity of the toe in a diabetic foot? It is clawed foot,
it's a claw.
right?
Yes, sir.
So you
Clawed
find
foot.
that
Yes,
they
sir.
walk like that and the pulp gets flattened.
That's right.
Also
Okay, sir.
because
Thank you,
of,
sir.
look, what is the most important problem in diabetic foot? Is it blood supply? Is it nerve supply? Is it sugar? What is the most important thing there?
The neuropathy.
Yes, neuropathy is most
Yes.
important.
Yes,
And
sir.
neuropathy, both motor, sensory and autonomic.
Autonomic, sir. All three
Right.
motor.
Right.
Yes.
So how do you, autonomic is very important here. And how do you test for
Sir,
that?
sir, autonomic neuropathy means, sir, there is increase in excessive, so decrease in sweating. So patient has
Right.
fissures, cracks.
Right.
So
Most
that's what,
important.
yes, sir.
So
That's why
have
again
you,
and again this trauma.
so have you mentioned that?
No, sir. I should have mentioned about cracks if
Right.
there's any on the sure, sir.
Right. You have to do that. Also, what about
Yes.
sensory?
So in sensory, there is a loss. So the first is the fine touch, which is lost. So sir, there is a hyperesthesia. So
Single
जैसे
monofilament touch.
yes,
Single monofilament touch.
monofilament. There's an instrument we use, sir. Seam Winston's
Right.
10-gram
Right.
monofilament for that,
Right.
sir.
Very good. Okay. Good.
Yes, sir.
Good. And what about motor?
Sir, extensive muscles of the foot get
Right.
wasted. That is why, sir, there's
Right.
deformity.
Right. So all that has to come. Okay. Next slide.
Yes.
Let's go to your last slide now. You have not mentioned about gait. Is the patient walking? Can he walk?
Yeah, yes, sir. He was walking, sir. So he was
Does he
walking
use any
with
support?
support. Yes, sir, with
Yeah.
support,
So
sir.
you have to mention that.
Yeah, sure, sir.
Right.
Shakil, you have not mentioned about ulcer.
Sir, I mentioned about the ulcer, sir, at the starting, sir. So the approximate size 6 into 4 centimeter ulcer over lateral aspect of foot on the dorsal region, sir. I have mentioned it, sir.
This much. Other points regarding ulcers.
Sir,
Okay. Like
this.
Dr. Shakil, is
Yes,
it a
sir.
wet? Is the ulcer infected or not infected? Right? Is
Sir,
it
there was
healing
no
or
pus
not healing?
discharge. It was healing with no pus discharge, sir.
So by the picture, it looks like it's healing. Why do you think it's healing?
Yes, sir, because granulation tissue is coming, sir. That's why it's
Very good.
healing, sir.
Very good.
Yes,
Yes, you can see that
yes,
in this.
yes.
Okay. Okay. Now, how will you manage this patient? Let's go to that. Well, we'll talk about your management about your history as we go along. Examination.
So, first of all, I would like to get all the biochemicals and parameters to know what are the comorbidities and associated things, sir. जैसे कि first we'll go for the complete hemogram to look if the patient is anemic or not, or his blood profile. So then because of the sugar, so we will get a complete RBS and HbA1c of the patient. So we will get a complete KFT, kidney function test, because the patient is diabetic. So there is some effect if on the kidneys is present or not. So we can have a LFT and triglycerides to look for any atherosclerosis or hyperlipidemia in the patient. Sir, these are some of the biochemical tests that we can do. Then, sir, we can go for imaging. Sir, if there is heart-related issues, so then first we will have an ECG and 2D echo of the patient. And sir,
Dr. Shakil, hang on. Dr.
Yes, sir.
Shakil, please.
Yes, sir.
2D echo, all that comes much later. What is the first imaging you do in this patient?
First imaging, sir, that the most routine and we do is, sir, X-ray foot is first is done, AP lateral, we can see
Right.
there's deformity or not, and then, sir, USG Doppler is done, sir. Arterial venous Doppler.
Exactly.
Yes,
ECG
sir.
and all will be there, but it's not.
Yes, sir.
You have to come to a diagnosis first, right?
Sure, sir.
Right.
What is the difference between USG and Doppler?
So in Doppler, we'll get ultrasound plus B Doppler plus B mode ultrasound is both is present, sir. In this, the flow of the blood vessels as well as the anatomical variation is seen, sir.
And what is duplex?
Sir, sorry, sir. In duplex, we get to see both the things, the flow and anatomical variations. Sir, in USG Doppler, we can only comment on the flow, sir, and velocity, sir. Flow.
No, there are three things. One is USG.
Yes, sir.
Another is Doppler.
Yes,
and
sir.
third is duplex.
Yes, sir.
So duplex is a combination of the USG
of USG and Doppler.
plus
Sir.
Doppler. So by
Yes,
USG,
sir.
what are the things you see?
So, by USG, we can see, sir, the flow of the vessel, sir.
No, you do not see the flow of the vessel in the USG. That is why you
So,
do the Doppler.
okay, sir.
In the USG, you
Doppler.
see the
Okay,
anatomy.
sir. Anatomy, sorry, sir. I just got
Yeah.
confused. Anatomy, and sir, in Doppler, we see the flow. Yes, sir.
Physiology. You see the
Yes,
physiology. And in the case of
yes.
duplex, you see both
Both, sir.
anatomy as well as the physiology.
Physiology.
Now, what is the normal arterial wave?
Yes, sir.
What is the normal arterial wave?
Sir, the arterial wave, sir, there's systole, then diastole, and then, sir, there's a laminar flow. So, in systole, when the pressure is present on diastole, sir, it is the reverse of the flow,
Dr.
and
Shakil,
laminar.
Dr. Shakil,
Yes, sir.
you say triphasic. Just say triphasic. Okay.
Yes, sir. Triphasic.
What
Yes,
are
sir.
these three
Triphasic.
phases?
Yes, sir.
What are these three phases?
Sir, these are the phases: systole, diastole, and laminar flow. So, if there is a in
No, Dr.
triphasic
Shakil,
wave,
Dr. Shakil, it is
yes,
not
sir.
laminar flow. It is the rebound of the
It's
vessel
the
wall.
recoil. Yeah.
Yes, recoil.
Right. Okay. So normal wave is a triphasic wave.
Triphasic wave,
So
sir.
when it
Yes.
is abnormal, what it is called as?
Sir, it is, we proceed to biphasic, and then, sir, it is monophasic.
Okay. So in the arterial waves, what are the things you see? One is whether it is becoming triphasic or whether it is biphasic. What else you see?
So,
So
one,
may
it
I
is
ask him
that it
something
is.
first? So may I ask him something first before he answers your question? Which is the first wave to be lost?
So, in terms of triphasic, or sir, in systole or diastole. So, in which sense, sir?
We said there are three things: systole, diastole, and recoil. Which
Yes,
is the
sir.
first to be lost?
Sir, the first is recoil, sir.
Right. Because it is because of the hardening of the wave. Right.
Yes.
Now answer Sir's question.
Yes, sir.
What is amplitude?
Sir, amplitude is of, sir, it is done through 8 mode of USG. Sir, amplitude of, sir, amplitude of vessels, are you asking?
I think so, yeah. Okay, in a case when there is a obliteration is there, the amplitude goes down.
Yes, sir.
Okay. So even if it is still the triphasic, there may be still low amplitude may be there.
Okay, sir.
Okay. So
Sir,
these are the things you have to see on duplex scan.
duplex scan.
Right.
So is the amplitude about strength of vessel?
Dr. Shakil.
Have you ever seen a
No.
wave like that? Okay,
No,
it goes
sir.
like this and then it is like this,
Okay.
So this amplitude which is there, okay, this one,
Yes.
this goes down.
Sure, sir.
The height of that amplitude, the wave which is there, it becomes less and it becomes widened. So it becomes less and it becomes widened. So that is also abnormality which is there on the arterial wave.
Yes, sir.
So what is the normal flow rate in an artery then? Like you said, Sir said there's the widening and there's the loss of amplitude. It shows the flow rate. What is the normal flow rate in an artery?
Pardon,
In a
sir?
peripheral artery. In a peripheral artery. Normal flow
So
rate in a
pardon?
peripheral artery.
Normal.
What is the normal flow rate in a peripheral
In
artery?
artery,
You know.
sir?
Yes.
So in femoral artery, it is around 300 to 600 ml per minute.
ml per minute. It is in centimeters per second. That's the flow rate. Right?
So popliteal artery, it is around 150 to 300.
No, it is more than 50 centimeters, 35 to 50 centimeters per second. Right? So what happens when the artery gets narrowed? Will the flow rate increase or decrease?
So the artery gets narrowed. So the amount of the flow rate, sir, will decrease.
No, it will increase.
Increase.
That is what
Yes,
that's
sir.
Poiseuille's law, no? It will decrease
Yes,
only
sir.
after when the diameter is of occlusions more than 50% of the diameter of the cross-sectional area. Right? Okay.
Yes, sir.
Let's sir, continue, sir, please.
Okay, so you will, why you want to do X-ray of the foot, you said, as the first investigation?
Sir, that is, sir, for routine, just to look for any deformity, or sir, just to rule out any deformity of the foot, sir.
Okay, tell what are the things you see on a plain X-ray of a diabetic foot?
So, on a plain X-ray of a diabetic foot, one thing which we can see is, because of diabetic foot, margins of the foot can be on an X-ray could be an irregular, sir. If there's an ulcer or something.
No, we are talking the
No,
bones.
no, no. X-ray, in
Yeah,
X-ray.
okay,
He's talking of
bones.
X-ray.
Bones and
Okay,
some
sir.
other calcified things you can see on the diabetic foot.
So one is calcifications can be present, sir.
Where you will see the calcification?
So on medial malleolus के पास, sir.
No, no, the arteries, na?
Yeah,
In
okay,
the
sir.
arteries
In
you will
the
see the
arteries.
calcification, huh?
Yes, sir.
And then there can be osteomyelitis may be there, osteoporosis
Osteomyelitis,
may be
sir.
there. There may diabetic foot itself causes a lot of the bone deformities.
Yes,
All
sir.
the things you can see on a simple X-ray.
Yes.
Okay. Then how
Okay,
do
Dr.
you
Shakir. Sir.
When you have kept the probe, how will you identify your probe is kept on the vein or artery? How will you differentiate whether your probe is on the vein or artery?
So, ma'am, if it is compressible, it is, so, ma'am, vein.
Yes.
Yes. Thank you,
Right.
ma'am.
Which is the probe frequency used for the Doppler? What is the frequency of the probe?
Pardon, ma'am?
Yes.
Ma'am,
Whether
I'm
it
not
is a
able to.
linear, convex, or
Ma'am, for this USG Doppler, ma'am. Ma'am,
yes.
low frequency probes is, ma'am, sorry, around, ma'am, medium frequency probes are basically used, ma'am, for
So it will be
femoral
around
artery
7
or
to 12. 7
ma'am,
to 12 to
7 to 10.
14.
7 to 10. Yes, ma'am, 7 to 10.
And it is a linear probe.
Okay, Dr.
Yes, ma'am.
Right. Yeah, Dr. Shakil, now how will you manage this patient? Let's quickly wind up.
Sir, after doing all the investigations, if it is so suggestive of a, sir, a diabetic foot, and sir, after saying if there is ulceration is present only, sir, we can go for
Look, your
debridement
patient,
of.
Dr. Shakil,
Yes,
your patient has
yes,
got
sir.
hypertension. He's got
Yes, sir.
hypertension. He smokes. He's got
Yes,
alcohol,
sir.
and he's
Yeah.
got diabetes.
So
We don't know about cholesterol, but he must be having hypercholesterolemia also.
first I'll go for the lifestyle modification for the patient, because that is the most important
Right.
thing in treating a patient with diabetic foot patient, sir. So, sir, first smoking cessation and alcohol abstinence should be done,
Smoking
sir.
cessation. How you tell him to stop smoking and stop smoking the next day? Is it possible? His wife must
No,
have been
sir.
eating his head his whole life
Yes.
for last 65
Ye-
years to stop smoking.
Yes, sir. But
So,
as a part of management, it is also a very important thing to at least
no,
counsel
what will
or
you do? Yeah, counseling.
yes, sir,
Counseling is effective
counseling.
in about 30. Repeated counseling helps in about 30 to 45 patients. What else?
Yes, sir. We'll tell about the effects of the smoking and we'll
That's
counsel.
fine. What
Yes, sir.
else? What else? Quick.
Sir, after doing the counseling, sir, the lifestyle modifications should
No,
be
anything
tell
else to stop smoking? Hang on. Anything else to stop smoking?
Stop smoking. Sir, nicotine tablets
Right.
could be used.
How
Yes,
much?
sir.
How much?
Sir, it's in micrograms, sir, or
No, it's in
something.
milligrams. 25
Milligrams, so
milligrams.
25
nicotine.
to 50
25
milligrams. Yes,
milligrams.
sir.
Right?
Yes, sir.
Or one
Yes, sir.
tablet every 2 hours.
Every 2 hours.
Right. What else?
So, smoking, counseling, and nicotine should be then, sir. Then we'll go for alcohol the
What about
abscesses, and then
e-cigarette? Can you give him e-cigarette? Can you give him e-cigarette?
sir, e-cigarette is also hazardous, sir. There's element of nicotine present in that also, sir.
Right. But you can regulate the amount of nicotine being given.
Yes, sir.
Right. Okay, what else? What else? What are other lifestyle modification?
Sir, other lifestyle modification, care of the foot should be explained thoroughly to the patient, sir. Yeah.
Control of hypertension, control of
Yes, sir.
hyperlipidemia,
And yes, sir, I'm coming to that. But
control
I'm
of
just
sugar.
coming to yes, sir. First thing, I was just telling care of the foot. He should not walk barefooted. He should have soft rubber slippers. Yes, sir, care of the foot. कि ज़्यादा dry नहीं रखने को. He can use moisturizer. Then, sir, I'm coming for the medical management of the comorbidities or the associated disease, sir.
Okay, done. About this patient now. About his foot.
Yes, sir. Sir, after care for the foot, and then sir, we'll look for the hypertension part, and sir, we can
No,
start with the
done.
Yes, sir.
Sugar done,
Yes, sir.
hypertension done, cholesterol done, everything done. About the foot.
Sir, now, if the patient, as far as in this patient, the ulcer is healing and have a good granulation tissue, sir, so we can have a serial debridement of this wound, sir. After
You think he
having
requires debridement now? Just go to the picture. You think he requires more debridement?
No, sir, not now, sir. मतलब कि he already had 2
I'm
sessions of
talking about
debridement.
now. Don't say in future. In future, he might be
Okay.
doing anything. Tell me now.
Sir, by now, we can get a grafting done for this wound, sir.
How can you graft now? What? Oh, tell me the criteria for grafting.
So the criteria is for grafting is that a healthy granulation tissue should be present, sir. And
Okay, one.
मतलब कि जो
What do you mean by
yes,
healthy?
sir.
What do you mean by healthy granulation tissue? What do you mean by healthy?
So healthy, sorry, dead granulation tissue, sir.
Okay, granulation. What else?
So then no associated infection or inflammation,
What
infected
there will be
neonates.
some infection. There will always be some infection. What infection is an absolute contraindication?
So for grafting, sir, if there's osteomyelitis or abscess pus present in wound.
What infection? What infection?
So
Strep
organism
or,
wise,
or pseudo?
Okay, so pseudo.
Strep and pseudo. Either of the
Okay, so
two is
both.
an absolute
Okay.
contraindication.
Yes, sir.
Right. So how do you do that? How do you find there's how do you find that there's no strep or pseudo there?
So we'll take a swab sampling of the wound
No,
and send it for
swab will come as contamination. Swab comes as contamination.
Okay.
You have to do a tissue biopsy.
Tissue biopsy. Okay.
Tissue culture. I'm sorry, tissue culture. Okay.
Tissue culture. Yes, sir.
What else? How will you improve the flow rate there? Okay, what are the conditions required for healing of a wound?
So for healing, sir, proper collagen healing. So, मतलब
How
sir
will you give
criteria.
collagen? How will you give collagen? Hang on here, Shakib. How will you give collagen? Collagen कहाँ से दोगे तुम?
मतलब sir collagen we can use dressings for healing sir early.
What are the modifiable factors which help in healing?
So modifiable factors in
any wound healing. What is required?
Shakil, what about the blood supply? Your ultrasound
Hemoglobin.
Doppler was showing.
Right. You require hemoglobin.
Yes, sir.
Hemoglobin should be more than 10.
Yes, sir.
Count should be less than 10.
10,000.
Protein should be how much?
Sir, protein should be more than sir around sir 5 or 4.5.
More than 5. Albumin should be more than.
Sir, more than 3 to 3.5, sir.
Okay, more than 3, right?
Yes, sir.
There should be no edema. There should be no infection. All this is there, right?
Yes.
Then you have to increase the flow rate. How do you increase the flow rate? Are there drugs to increase the flow rate?
So flow rate.
What are the medicines you give?
So in diabetic foot, so we can give.
Can you give any vasodilators?
Dilators can be given, sir.
What?
Dilators.
Okay.
So what we use no, so I'm sorry, sir. Yes, sir, silastazole, sir, phosphodiesterone. Yes, sir, silastazole
Right.
can be given, sir. Yes.
Right. What else did you give?
So then, if the patient is having anti-cholesterol, sir, atrovastate, statins can be given, sir.
Any statin can be given.
Yes, sir,
Right.
80 mg around OD, sir.
What about his pain?
Sir, we can give analgesics or so for pain relief, sir.
What analgesic will you give usually? What is given?
Sir, normal.
You have to give a synthetic opioid. What's that?
So synthetic opioid can be
Tramadol and the new kid on the block. Tapentadol.
Yes, sir, tramadol.
Tapentadol.
Yes, sir, tramadol, sir.
Tramadol and tapentadol, which is the new one. Okay.
Sure.
What else? What else? What is offloading?
So offloading is the redistribution or reducing the pressure over the wound area, sir.
So how will you do that in this patient? He's having ulcers or gangrene over the one on the left. On the right, is it on the little toe? And left
Yes,
also
sir.
on the little toe, no?
Yes,
or
sir.
The second toe or whatever. So how will you do offload?
So by reducing soft loading techniques can be used.
So you got to where there is ulcer, that you do have to keep the weight away from that place. So you support on the heel, so that the forefoot is hanging in the air. All the weight is on the sole, isn't it? You have to reduce the edema.
Edema, sir. So we can.
Right.
Yes, sir. That can be used.
If you ask him to use an exercise cycle, so that at least the limbs he can move more and the collaterals will open up.
Yes, sir.
So anyone, ma'am, please.
Yes. Now, what about the special footwears? How you can modify his pressure points? How will you teach the patient to take care of this footwear? How to walk with it? How to adjust with it? Accordingly, the normal limb has to be modified. So these are all the quality index parameters by which you complete the treatment, Dr. Shakib. It is not only about the healing of the ulcer, but the long-term goal is important, like healing, whether you are dealing with the supply has been normalized or not. Third thing is the long-term sequelae, like patient cessation of smoking and alcohol parameters. Then what is the follow-up of this patient on the long-term and short-term goals? What will you do the follow-up examination? Suppose this patient ulcer heal, you have done the grafting, patient is using the modified footwear, and you are asking the patient to meet after every 3 months. What will you look after?
Ma'am, firstly, after every third, ma'am, in every follow-up, RBS should be, ma'am, monitored whether the patient is compliant to all the diabetic precautions or diet, or whether it's the IBS or the RBS is above range, ma'am. The first thing you should look for it,
Suppose
ma'am.
blood tests are normal. Blood tests are normal. What will you examine locally? What local examination will you do? Physical examination will you do? Suppose blood tests are normal.
Yes, ma'am. Ma'am, in physical examination, ma'am, in the limbs, I would look for any diabetic. Ma'am, for pulses examination.
Yes. First you look for your graft and peri-graft area.
Yes, sir. Graft, whether the graft uptake is healthy or not, ma'am, in follow-ups.
Yes. What about the next ulcer forming areas? Is there any ulcer forming area?
Yes, ma'am.
New pressure point necrosis is there or not? Isn't it? What is
Yes,
the
ma'am.
interdigital cleft? Is it healthy or not? Is he taking the nail care properly or not? Isn't it?
Yes, ma'am.
Then comes the pulse examination. Okay, the vascularity
Yes.
of the limb.
Vascularity
So
of
what
the
will you
limb, ma'am.
Yes. So what will you look for the vascularity on Doppler? What will you ask the radiologist to look for?
Ma'am, to look for the flow in the artery, with different arteries, ma'am, supplying the foot. One thing is that, ma'am.
Yes. Only the affected limb or the normal limb also?
Ma'am, normal limb also, because there's risk of getting into that limb, ma'am, both limbs.
Okay. Okay. What else you want to ask? Rajiv sir has taken into a good discussion and he has
Yes,
given
sir.
you lot of inputs, even to
Yes,
the
sir.
us also. He has taken into a very great detailed discussion so that it completes the case. But
Thank
still,
you.
whatever you want to ask,
Shakil,
you want to
what are
ask.
the various ways of debridement of the wound?
Sir, different ways.
Yeah,
Sir,
what are the various
one,
ways of debridement of the wound?
sir, one is mechanical debridement.
Yes,
The other is, sir, the chemical debridement.
yes.
So mechanical, physical, and so enzymatic debridement, sir, is present.
Yes.
Enzymes होते हैं, सर, वो ले लेते हैं एक, sir. Then there is autolytic debridement.
Mm-hmm.
Topical agents are used, sir. These things I know, sir. Then there is hydrosurgery debridement, sir. It is recent advancement, but sir, hydrosurgery, use of high pressure jets.
Yes.
And
You
sir, one
can
is laser
remember it
debridement.
by the word beams.
Beams.
B-E-A-M-S.
Okay, sir.
B stands for biological.
Biological.
E for enzymatic.
Enzymatic.
A for autolytic.
Okay, sir.
M for mechanical.
Okay.
And S for surgical.
Thank you, sir.
Okay, so that will cover all the things. So how do you do the biological debridement?
So in biological debridement, we use certain. So is it the biological debridement is usement of,
Certain fries are
sir,
used.
larval therapy, sir, होती है,
Yes.
larva की therapy होती है, sir.
Green bottle fries are used.
Yes,
Half of
sir.
that is used for
Yes, sir.
biological.
Yes, sir. Maggots or larva therapy, sir.
Okay. Now, can you tell what is the time principle of wound?
Sir, time
Time
principle.
principle, yeah.
So different phases of wound, or
No, there is
sir,
a
do you
specific
want to
time
ask?
principle for any wound. You have to take 4 words in your
Okay, sir.
treatment
The
for that.
phases जैसे inflammatory phase होता है, sir, वो 0 to 4 days लेता है.
नहीं, टाइम क्या है? टाइम TIME.
अच्छा, sir. Sir, time. So I'm not. Sir, sorry.
T is for
Go on.
tissue.
Okay, sir.
I is for infection.
Okay, sir.
M is for moisture.
Moisture.
And E is for H.
Okay, sir.
Okay. So you have to see the time means the T, that tissue
Okay,
should not be dead.
Okay, sir.
You have to control the infection. You have to keep the wound moist.
Yes, sir.
And you have to check the edge of the wound, that is it healing or not. So that is called the time principle for wound healing.
Thank you so much, sir.
Okay. Now tell, what are the various ways of revascularization of the limb? What are the
Sir,
various ways you can revascularize the limb?
So, different ways we can revascularize a limb can be, sir. One is a thrombolysis. Thrombolysis can be done, sir.
Good.
Then, sir, thrombectomy can be done.
Okay.
And artectomy can be done, sir.
Okay.
Then, sir, angioplasty or stenting can be done, sir.
Okay.
And, sir, bypass grafting.
Right. Now,
Shakil.
if it is a disease which is involving the below the inguinal ligament, What type of the surgery will do?
So below inguinal ligament.
Yeah.
So I would be going for aorto femoral bypass grafting. Yeah, aortoiliac.
So will you like to use a prosthesis there, or will you like to use a vein there?
Sir, I would
If
like
it
to
is
use a
below
vein.
popliteal is there.
Sir, if the obstruction, I have to get a vascular surgery below a knee or popliteal vein, then
Yeah.
sir, I can use both a saphenous vein or a mesh, a Dacron or PTFE mesh, because sir,
This is
as
not
we
called
go
as
below.
mesh, na?
Sorry, sir.
This
It's
is not called as mesh.
yes,
You know,
sir.
mesh, you understand what is the meaning of mesh?
Yes, sir.
Mesh
That's
has
if
got
we
so
use
many holes
hernia.
in that, na?
Yes, that's hernia. So basically, if below the knee, if we are getting a graft, then we can use both a saphenous graft or a Dacron or PTFE graft. So because as we go down the limb, the vessels are very small, so we can use a synthetic or artificial graft. But as we go above the knee, sir, then it is suggested that saphenous graft is best, sir.
No. I think always the saphenous graft is best.
Yes, sir.
That is the
Yes, sir.
autogenous which
Always.
is there. It is always best. If it
Yes,
is
sir.
possible to use that, always prefer it over the
Yes, sir.
synthetic graft. Okay.
Yes, sir.
Right. What is the role of stem cell in like this type of the patients? Any idea?
So stem cells can be used, sir, as a method for improve wound healing, sir. These are new method of tissue engineering which helps in wound healing, sir. Adhesion और ये सब में help करते हैं, sir. Tissue engineering के regenerative principles के new methods हैं, sir.
ओमेंटोपेक्सी नाम सुना है, ओमेंटोप्लास्टी नाम सुना है कभी फॉर रिवेस्कुलेशन पर्पस? हैव यू हर्ड अबाउट दैट?
सर यू सुना है, लेकिन वो हम सर्जरी में अपने एब्डोमिनल में ज्यादा, सर या आई हैवंट हर्ड, सर.
हैं?
सर सॉरी सर, आई हैवंट हर्ड इट इन रिवेस्कुलराइजेशन
कुछ
पर्पस.
लोग यूज करते हैं ना, दे ब्रिंग द ग्रेटर मोमेंटम फ्रॉम द एब्डोमेन एंड ब्रिंग इट अप टू द एंकल एरिया जो है, so that there
Dr.
can be
Shakil.
increased circulation.
Yes, sir.
So that is also
How
one
will
of
you predict poor outcome in diabetic patient? Diabetic foot infection?
Yes, sir.
How will you predict poor outcome in diabetic foot infection?
So if the patient has recurrent ulcers or if present poor diabetic control, one is sir poor या uncontrolled diabetic control, sir, so it will be a poor outcome. Yes, sir.
Okay. In
And then,
diabetic
sir,
foot infection,
yes, sir, in diabetic foot infection, if the patient has high level of RBS or uncontrolled level, so there will be chance कि sir poor outcome रहेगा. And then, sir, if there is a sensory neuropathy involved, तो sir poor outcome के chances रहते हैं.
isolation of MRSA, increased WBC count, increased CRP.
Yes, sir, these are parameters for infection or poor outcome, sir.
Continue.
Yes, sir.
Kanna sir. Anjali ma'am, would you like to ask any other questions, ma'am?
No, sir. I have done. I have done. Shakil, you have done a wonderful job.
Yes, sir.
Thank you so much, ma'am. Thank you so much.
Very nice presentation, Dr. Shakil.
Thank you so much, sir.
Sir,
Thank you all for support, sir, and for your words of wisdom, sir.
Kanna sir, can we call a close, sir? Rajiv sir?
Yes, sir, please. I think he's done a good job.
Thank you, Dr. Shakil.
Thank you so much, sir.
Yes, sir.
Shakil, I just wanted to tell you, like these patients who present with the ulceration, all those things,
Yes, sir.
saying that lifestyle modification is the first treatment, that is not. You cannot do anything
Okay,
at that time. At that time,
Okay,
you
sir.
have to control the pain of the patient. You have to control the infection of the patient. You have to control the diabetes of the patient, and you have to revascularize that limb. Only
Okay,
after
sir.
that, the patient may
That.
stop smoking and patient may not take the alcohol and all those things. And hyperlipidemia, you have to definitely, and hypertension, diabetes has to be controlled. So never say the lifestyle thing as in this type of the patient as a first treatment for that. First treatment here is to control the pain here.
Yes, sure, sir. Thank
Control
you
the
so much, sir.
infection, control the diabetes, and then revascularize that. And take care of the local wound which is there. Okay?
Yes, sir.
Yeah.
Thank you, sir.
Thank you, Dr. Shakil. I thank Dr. Hemant sir for also kindly letting you to present a case here. And with the permission of the faculty, we call this session a close. On behalf of all the faculty and the students of PG Clinics, we wish you all a very happy and prosperous new year. Hope to meet you all in the new year with a little faster format. We'll have an internal meeting with our own faculty and take a call about what are the new changes which we are going to try to bring in the year. Probably we'll have a reduced time session, but we will continue to have this 2 cases format. That's the plan. And anyway, we'll discuss internally with the group and then announce what are the finer changes which are going to have for the subsequent year. And we also wish and request those who want to present a case here can reach out to us directly, to one of the faculty or to one of us. And then we once again, we wish you all the very best. And then we'll meet on the coming Friday. Can we call a close all the seniors here?
Good night. Thank you so much.
Good night, sir.
Good
Thank
night.
you.
Good
For
night.
the
Good
wonderful
night.
opportunity.
Good
Good
night.
night.
Thank
Happy
you so
New
much,
Year.
sir.
Thank you. Thank you, sir.